Hello, my name is Winfried Amoaku from Nottingham, and I'd like to tell you about the macula and common diseases that affect it. And my plan is to tell you a little bit about the macula. We'll talk about the common tests and investigations that we do in the clinic, including optical coherent tomography, fundus fluorescein angiogram, fundus autofluorescence, and microperimetry. Then we'll talk about the common macular conditions, the macular dystrophies, age-related macular degeneration, diabetic macular edema, retinal vein occlusions, and then we'll talk about the treatments that are available for these common diseases as well. Just to put things into context, the eye, as it exists, makes images of objects that we would like to see, and these images are transmitted through the optic nerve to the brain. So the light enters through the front of the eye and is focused by the lens onto the retina, and the retina transforms these light images into electrical signals, which are transmitted through the optic nerve into the brain. Now, the way God designed the eye, it avoids interference. So the retina is on the innermost part of the eye wall, and so that there are nothing interferes with the light focusing. So when you look into the eye, as we do in the clinic, you should be able to tell. What is normal and what's abnormal, and the images you can see in this slide depict what we see when we look at the back of your eyes. Now, the image on the left-hand side of the slide shows the optic nerve in the center with the blood vessels coming out of it, and the macula is on the right-hand side of that particular image. Whilst on the image on the right-hand side of this particular slide, the macula is on the left-hand side of that right-hand side image. But you notice the blood vessels are the same in both. The slight difference between those slides is one is the right eye and the other is the left eye. But in addition, the background looks darker in the image on the right-hand side because that eye belongs to an African which has more pigment in it compared to the Caucasian on the left-hand side of the slide, which has less pigment. So the macula is a large area, which is shown by the large white circle on this slide, but the center of it is the fovea. That's the smaller circle in the center is the fovea, and it's the fovea actually that is responsible for your fine detail vision and color vision. But the larger area contributes significantly as well. So any condition that affects that central area or the larger area are important as far as we're concerned. So this image here shows you a scan of the back of the eye called the ocular coherent tomogram or tomography, short OCT, which most of you would have heard in the clinics. And the OCT gives you, it's a very fine invention. It gives you a cross-section view of the retina. So you can see the different layers in the image, and those different layers you will be able to analyze, and you will notice there's a little dip in the center of that image there on the right-hand side, and that is the fovea, the area responsible to the fine detail vision, as I referred to earlier. Now, this slide here has two different panels. On the left-hand side is what we used to call the traditional fundus fluorescein angiogram, where we inject a yellow dye into your arm, it flows to the back of your eye, and we take a series of photographs to depict the flow of the blood vessels in the retina and the choroid, and this will show whether they are normal or not, and whether there's any leakage. You'll see the nice pattern of capillaries, which is the white fluffy bits there. Now, on the right-hand side of the slide is a more recent advancement called the OCT angiogram, which tries to mimic or actually record the blood flow at the back of the eye without giving any injection at all. So you notice the images are not as clear as that you see in the fundus fluorescein angiogram, but for clinical purposes, they're great and avoids that extra step of the injection of a yellow dye. Now, this next slide we call the fundus autofluorescence, and you will normally there's a substance produced in the retinal pigment epithelial cells that we call lipofuscin, and this accumulates with time. Now, in the retinal pigment epithelium, they fluoresce if you use the particular and appropriate wavelength of light, and we call that reflection of light back as autofluorescence. So, but in some certain conditions, you lose that autofluorescence. For example, in this case, with geographic atrophy or dry macular degeneration, the dark areas there show you where the photoreceptors and the retinal pigment epithelium have been lost, and therefore map out very well for you which areas the patient cannot see in. Now, the microperimetry, this looks like a busy image, but it's very simple. So if you look on the top left image, there is a little circle there, and that circle determines or measures the sensitivity of that particular part of the retina. So we show specific light wavelengths and intensity at the back of the eye, and the patient presses different buttons, and we record the sensitivity of that little part of the retina, whilst the image below that shows you how well the patient is fixating. The green, yellow, and red images, that's just tell you how to interpret the image, whether it's good fixation or poor fixation or poor sensitivity, and so on and so forth. The image on the right-hand side there shows you examples of what is abnormal in geographic atrophy. But so not every clinic has a microperimetry, but it's becoming more and more common that we use it in research. But who knows, in a few years' time, it might become part of normal clinical practice. So the different macular diseases I'd like to talk about briefly will be the macular dystrophies, age-related macular degeneration of the different types, retinal vein occlusions, diabetic retinopathy, and then we'll mention one or two other things that might be of interest. So retinal dystrophies. Retinal dystrophies are actually diseases where we lose retinal tissue in different ways and shapes. We say loss of tissue, and that can be inherited or not inherited. Or to put it in a different way, the non-inherited are sporadic. But most of them are conditions that will become inherited subsequently because there's been a new mutation, or that the parents of the particular individual who has the condition has the recessive gene that was not known about, but then it's become obvious. So several genes have been found for retinal dystrophies, and the number keeps going up every day. So now, theoretically, if we discover the abnormal genes responsible for a particular retinal disease, then that should lead to us trying to find treatments for those conditions. And these therapies will be designed to overcome either the abnormal functioning gene or suppress the production of abnormal proteins due to the faulty gene, or replace the function of a lost gene. So there are different ways why it's important to find those genes. Now, this slide here shows you two examples of retinal dystrophies. On the right-hand side, you have an image of what the fundus or the back of the eye looks like in Stargardt's disease, while that on the left-hand side shows you the different or one particular version of retinitis pigmentosa. Now, remember, retinitis pigmentosa in particular is quite, common, but it has different variations, and over 40 genes have been found so far for retinitis pigmentosa. Now, what about the age-related macular degeneration? It's the commonest form of visual loss in the elderly in the Western world. And in early age-related macular degeneration, you have fine yellowish deposits at the back of the eye in the macula, and on which is shown in the top image there. Now, the OCT, which is below, shows you the little bumps on underneath the photographic film, and those bumps represent the accumulation of drusen. Now, the importance of this drusen is that the photoreceptors overlying the drusen will slowly malfunction or die over time. And some of the time, the drusen get larger as well. And in the process, the whole process will subsequently lead to intermediate AMD or later late AMD. So this slide here shows you larger of those yellow deposits, which make it more obvious. And you notice the bumps on the OCT scan are more obvious and larger. So, and you may have some pigment deposits at the edges of the drusen as well. So that's intermediate AMD. And usually, again, these patients may not have any symptoms, or they may only have slight difficulty in different types of illumination, but generally their eyesights are okay. And then, of course, once it progresses to the late stage, you have there are two forms: either the dry late stage called geographic atrophy, or the wet type, which is due to abnormal neovascularization. So we call it neovascular AMD or wet AMD. So the slide on the right-hand side is the wet AMD, and you notice there's a little bit of bleeding in the center there, surrounded by the yellowish deposits of drusen of different shapes and sizes. The slide on the left-hand side shows large drusen as well, the yellowish or whitish lesions, as you can see. But the center of it, the center of the macula there, you can see has a very well distinct area of what seems like an excavation. That's the area of geographic atrophy where tissue have been lost. So again, this slide here shows you different versions of geographic atrophy. On the slide in the left-hand side is the right eye, and I beg your pardon. And the slide on the right-hand side is a corresponding eye. You will notice the yellowish patches of different shapes, and that's complemented by the very well-defined area of atrophy called the geographic atrophy. And it's called geographic atrophy because when it was first described, they looked like, those little patches looked like maps. So it was called geographic atrophy. So depending on which particular part of the macula is affected by the geographic atrophy, again, the patient's vision may be severely affected or only moderately affected. In this case, in this slide here, you can see the OCT image of an eye of geographic atrophy, and you notice the fovea is just at the edge of that. So this patient's right eye here will be affected by the geographic atrophy. And the slide on the right-hand side shows a smaller patch of that geographic atrophy. And that patch is shown by the vertical lines, which look like a barcode, corresponding to the areas where the retinal pigment epithelium has been lost, and therefore there's a bigger patch of light transmitted through it. But unfortunately, because the photoreceptors are lost, the patient's vision is impaired. Now, this slide here is just to summarize that you can use the different tests that I've shown you, particularly in geographic atrophy. We try and combine the tests to give us more information in particular patients, and the particular combination will depend on the circumstances. So you see, this patient has an OCT scan in the middle there, middle of the bottom panel, whilst the top panel has the color fundus photograph, has a fluorescein angiogram, autofluorescence, and so on. And if you combine that with all the other bits, you have a better picture, particularly when you're trying to follow the progression of geographic atrophy. And this next slide here shows you that progression. So the image on the left-hand side of this slide there shows geographic atrophy. You can see the autofluorescence, the loss of autofluorescence, which therefore has made the patches, a lot of black patches. But on the image on the right-hand side of the slide, you notice the black patches have increased, and particularly where the arrowhead is pointing is where the fovea is. Now, in the right-hand side, the geographic atrophy has affected the fovea, so that patient's vision would drop significantly compared to what it was the year before. Okay, what about wet macular degeneration? Wet macular degeneration is due to growth of abnormal blood vessels from the choroid, that's the layer underneath the retina. These blood vessels will grow through the retinal pigment epithelium and then go into either the surface between the retinal pigment epithelium and the neuroretina, or bleed into the retina itself. So there's a lot of leakage, bleeding, and if you did nothing about it, then in the late stage, you will have scar tissue formed. It's as if you have a wound that is leaking initially, and or the wound on your skin, if you don't do anything about it, eventually it will heal and it will give rise to a scar tissue. That's exactly a similar situation as to what happens in the back of the eye. But once you have that scar formation, then the vision loss becomes permanent. Initially, you have distortion and blurring of vision, but if you did nothing about it, that becomes more intense and progressive, and when you have the scar tissue, and the visual loss is permanent. So on the OCT scan, you can see there are little, it's like the whitish patch underneath the retina there has accumulated, and if you did an OCT angiogram, then you get a picture similar to what we'll see in the fluorescein angiogram, where you have a nice lacy pattern of as the arrow is pointing to there, and these depict the choroidal neovascular membrane. Unlike fluorescein angiogram, where you take a series because the dye will leak from the network of blood vessels, there's no leakage here because we haven't put in any dye, but it tells you nicely about the appearance of the choroidal neovascular membrane. And on the bottom left patch here, again, this is showing the blood flow, and you can see that where my little arrow is, the red patch there represent the where the blood flow is highest. And that's important because if you treat the patient subsequently, as I'll show you, you'll notice that flow is reduced. So, but it's important to appreciate that apart from wet macular degeneration, wet AMD, as I would say, there are other conditions that can give rise to choroidal neovascular membrane formation in the eye, as in high myope, we call it myopic CNV, or PIC, punctate inner choroidopathy, or multifocal choroiditis, or serpiginous, or pseudoxanthoma elasticum, PXE. Of course, but there are a few others, less common ones. I won't go into that. But it's important to appreciate other things can cause choroidal neovascular membrane, non-AMD CNV, but we'll treat them. The treatments we give for these are based on the same treatment as we have for wet AMD. Diabetic macular edema, diabetes is very common these days, And diabetic retinopathy is a common cause of vision loss, and that vision loss is due to either leakage from the abnormal blood vessels, or we have new blood vessels growing called proliferative diabetic retinopathy. So this slide here shows you the leakage in different shapes and sizes. So the OCT scan here is the easiest to see. There's leakage of fluid underneath the retina as well as within it. So whilst the top image there shows you bleeding and exudates, which are responsible for the vision loss in this condition. Now, similarly, in retinal vein occlusion, you have the slide on the image on the left-hand side is a central retinal vein occlusion. So you can see it's as if somebody's thrown red paint on a wall. So these splatters are all over the place, and the macula is swollen there, and there's bleeding there. And that's what causes the blurred vision or the vision loss. While the slide on the right-hand side has the bleeding affecting only the superior part or the upper part of the retina. That's because it's only the superior vein there that is blocked. So we call that a branch retinal vein occlusion. But the effect is the same because you have blurring of vision, and you need to treat these patients to be able to avoid that blurring of vision. So what treatments do we have? So I will talk about treatments for wet AMD, dry AMD, diabetic macular edema, and the others. So the treatments for wet AMD are based on the discovery that the particular molecules are produced in these eyes, and these are what's responsible for the abnormal blood vessel growth and leakage. And the particular molecule, or the most important of these, is called vascular endothelial growth factor. And therefore, we sort of stretched that and said, as is similar to what is used in cancer therapy, if you block this vascular endothelial growth factor, or VEGF, you block the leakage of these abnormal blood vessels. However, unfortunately, the blockage is time limited because the molecules attach to the VEGF, but unfortunately, there's continuous or subsequent production of VEGF in the eye. We haven't found a way of stopping that yet, which is why we need to keep repeating the injections for a long time. And these anti-VEGFs, as we call them, include ranibizumab or Lucentis, aflibercept or Eylea. It's important to know there are two doses of Eylea. The original dose of Eylea was 2 milligrams, but there's what is now called Eylea HD, which is 8 milligrams. Then we have another one called brolucizumab or Belvu. Then you have faricimab, which is Vabysmo. And then you have bevacizumab, the licensed form of which is called Litanava. And then we have biosimilars. Now, biosimilars are based on the original molecules as listed above. And as the patent for these drugs expire, there are other companies that are producing drugs with similar molecules to what is in the original drug, which is why they are called biosimilars. And they've been tested for safety and have been found to have a similar property or function or works the same way as the mother molecules. So we have, currently we have biosimilars for ranibizumab or Lucentis because the patent is gone. The Eylea has biosimilars, but these will only become available in the UK in December or January next year. The other ones are very recent, and therefore the biosimilars will take some time to appear on the market. So this slide I showed you previously shows the choroidal neovascular membrane or wet AMD, as you can see there with the blood flow. And this was before treatment. And after we injected the patient a few times, you will notice the patch here, which represented the flow, is nearly disappeared. Okay. And again, the size of the lacy pattern in these top images have significantly reduced. So I'll just show you that again. You can compare. This is before treatment, and that is after treatment. And of course, the patient's vision improves. But unfortunately, we have to keep treating. Okay, what about dry AMD? Unfortunately, there are no licensed treatments for dry AMD in the UK or Europe at the moment. There are two products that have been licensed in the US called Syfovre or pegcetacoplan, or Izervay, which is called Avancicapad. And these, again, have to be injected into the eye 1 to 2 monthly, probably for the rest of your life. We only have evidence for up to 3 years to date. Now, these treatments we know reduce the progression of geographic atrophy. It doesn't stop it. It reduces progression of geographic atrophy, or the dry form of AMD, by about 12 to 15% every year. So that reduction, yes, will allow some further preservation of eyesight. But unfortunately, if the progression continues and it involves the fovea, then unfortunately you still lose vision. And it's because of all these that the regulators in Europe at the moment do not think it's cost effective. It's not a game changer, which is why they haven't approved either of these for treatment in Europe or in the UK. However, we believe it's the beginning of new things to come, and that we would be able to, based on the same things that have been done to date, we will be able to develop more useful treatments for geographic atrophy in the future, which will stop the process or much better, slow the progression much better than these other two products that have not been licensed. Now, the other things that you need to know about is that there's gene therapy being trialed for wet as well as dry macular degeneration. For the gene therapy, the aim of gene therapy in wet macular degeneration is to induce the cells in the eye itself to produce the anti-VEGFs, to produce molecules similar to either ranibizumab or aflibercept. And if you remember, I said there's recurrent production of VEGF, so you want to be on top of it. So if you have a way of producing the anti-VEGF continuously in the eye, then that negates the need for, or removes the need for, recurrent injections. So the idea is that if it works, one injection of the gene therapy is enough to last for years. However, as the gene therapy takes a while to work, you still need to give a few injections of the standard anti-VEGFs for the first 3 to 4 months. And then hopefully the gene therapy will kick in and then maintain treatments for a few years to come. That is still in the trial stage, but it's looking promising for now. What about geographic atrophy? So again, you inject a particular dye into a gene into the eye, which will interfere with the pathway that results in loss of the retinal pigment epithelium and the photoreceptors. Okay, now a particular gene that is being targeted at the moment is to allow the retinal pigment epithelial cells to block the last stage of the process that leads to the death of these RP cells. We say anti-complement 9 as part is the last process in the complement pathway that gives rise to the death of these cells. So again, that is being tried. It's in phase 2 at the moment. The idea is that, again, if you can stop those retinal pigment epithelial cells dying, then you preserve what is left forever and ever. But we'll wait to see those results. Now, some of you may have heard of another product by Gyroscope, Novartis, called GT005, which was to increase complement factor I expression in the eye in order, again, to progress against geographic atrophy progression. Unfortunately, that one has failed, and that study has therefore been stopped. But again, there is hope for the future, although we don't have anything to offer at the moment. What about treatments for diabetic macular edema? So the idea of treatment of diabetic macular edema, again, is to stop the leakage from the abnormal blood vessels and to get rid of the leakage, the fluid. So the top image there shows you fluid within the retina, and then the bottom one shows you the fluid has gone and the normal shape of the fovea has been restored, as you can see there. So the fluid is gone after multiple injections of anti-VEGF, and the edema has gone. But again, you will need to monitor these patients and treat them appropriately and repeat treatment as appropriate. Now, the advantage of the only advantage of treatments of DMO is that we can use steroids as well as anti-VEGFs. Now, steroids are usually of no use in the treatment of wet macular degeneration. So again, this slide here shows you edema. If you look at the top image there, there's fluid underneath as well as within the retina in an eye with retinal vein occlusion. Again, that has been received anti-VEGF therapy and the edema has gone. But again, you need to monitor these patients and treat as appropriate. What about macular dystrophies? Now, theoretically, the discovery of the abnormal gene will lead to therapies, as I've alluded to already. And these therapies are designed to overcome the abnormal functioning gene or suppress the production of abnormal proteins due to the faulty gene, or to replace the function of a completely lost gene. Okay? Now, gene therapy is a bit complicated because you have to get the gene into the eye to do the job, and you need to load the gene onto a particular, we call a vector, and those vectors are usually particular viruses, but depending on the size of the gene will determine how you can load it onto the particular vector. You can't carry a lot of things in the boot of your car, but you can carry a lot more things in a minivan or HGV. So same principle. So with the appropriate gene and the appropriate vector, you should be able to introduce these particular genes into the eye, which will modify the way the cells in the eye function so that you don't lose any more structure. But again, we hope. Things are limited at the moment, but we hope as our knowledge gets better and better, we will be able to improve what we have. Now, you have to remember, if you're introducing things into the eye that were not there, you got to think of the safety of the technique as well as the safety of the products that you are introducing into the eye. And all these will be taken into account when these developments are made. So again, this is just to show you some of the macular dystrophies and what we would hope to treat in the future. And on that note, I shall say thank you.